you can take a picture from this page. I will bring this back at the end. We don't have any affiliation or financial interest to organization that we mentioned the product of them today here. And about the objectives of the presentation, first, we want to talk about cancer treatment that makes the ocular toxicities. And second, we want to have some managements for those toxicities. And at the end, we want to provide evidence-based recommendations for treating cancer therapies which are associated to ocular toxicities. We start to talking about the anatomy of the eye as an introductory by a picture of a cross-section of eye. As you can see, eye has different compartments. First, cornea and interior segments. Second, uvea. As you can see, it includes iris, ciliary body, and choroid. 3, it is periocular and orbital tissues. And finally, retina, and as you can see, optic nerve as well, which we will talk about each of these compartments soon. Also, as an introduction, I like to talk about grading of the toxicities as well. Regarding to criteria of grading of the adverse effects in eye toxicity, I like to refer to CTCAE, common terminology criteria of adverse events, which it is a common toxicity. Common toxicity criteria, which is a set of criteria for the standardized classification of the adverse effects of the drug, which we use in cancer therapy. And CTCAE is a product of US National Cancer Institute. I'd like to mention that version 5 of CTCAE has 155 pages, and consider that 6 pages of them involves the definitions and grading of eye disorders. Generally, 26 eye disorders are defined there, which we can see toxicities like blurred vision, like corneal ulcer, dry eye, and many others. Based on CTCAE criteria, we know that generally grade 1 is a mild situation, grade 2, moderate, 3, severe, 4 is life-threatening, and grade 5 is the situation that the toxicity leads to death of the patient. The outline of management of ocular toxicity goes to 4 titles. Identifying root cause. The second one is localizing the affected place in the eye. 3 is covering and managing the common symptoms which we see in the patients. And 4 is providing a specific management for a specific anti-cancer treatment. First of all, let's go with identifying root cause. As we know, ocular disease can generally be severe in the patient, disabling, irreversible. So in the very first and initial step, it is very important to clarify what is the root cause of that ocular disease. As a general idea, we can consider that those diseases can have 3 root causes. One is the malignancy itself. The second is associated effect. And 3 can be the anti-cancer treatments which we are using for the patient. And we call it ocular toxicity from now. Talking a bit about intraocular malignancies first, and I would like to say that most of the common malignancies inside the eye is coming from metastasis. Besides the metastasis of the malignancies, which we can see in orbit, in optic nerve, and in places like retina, the most common metastasis involves the one in uvea tract. And as you can see in the picture, it involves iris, ciliary body interiorly, and choroid posteriorly. I should mention that in most of those situations which we have intraocular malignancy, the patient has symptoms like photopsia, like metamorphopsia, floaters, blurry vision, difficulty in focusing, and the points like actually this. Coming back to the first phase of identifying root cause, after talking about malignancy itself, the next one would be associated effect. I do not like to dig into that one so much, but I would like to mention that a very common type of that is paraneoplastic syndrome in the patients. And finally, the root cause, which is important for today's presentation, anti-cancer treatment. In the case of anti-cancer treatment, or generally ocular toxicity, as a very general statement, we can say that our approach is discontinuing anti-cancer treatment if we have a vision-threatening situation in the patient, and if not, we can continue the treatment. We will talk about that definitely more. Back into outlines. After identifying root cause, and if it is coming from anti-cancer treatment, in the very next step, we will go into localizing the affected anatomy in the eye. As I discussed it in introduction, we have a different compartment in the eye, which you can see it in the right side of the slides. For managing the ocular toxicity, it is very important to know that different medications can affect different compartments of the eye. And the approach to localizing the affected compartment in the anatomy is to focusing on the presentation and symptoms of the patient to find which compartment is affected. The very first compartment to talk about is cornea and interior segment of that, which you can see in the picture. Based on the physiology of this compartment, we can see that if damage happened to that, the manifestation of the problem will be changes in the clarity, the surface integrity, and the interior eye discomfort. The patient may have different feelings. The very important one is the dry eye and reflexive tearing. The patient may have a feeling of burning eye or having gritty or sandy or foreign body sensation. The patient may have sensitivity to light, which we finally see it as a blurred vision. Another symptom which is very important in this compartment is conjunctiva. And in the case of drug-induced conjunctivitis, we can see that the patients may have a specific symptoms like pinkish hue. And the last one to mention, which is very important, is blepharitis. We can see it as inflammation in the base of the eyelashes and maybe even inner portion of the eyelids as well. I would like to mention that as a very general idea, most of the patient which has issue in this compartment can be managed symptomatically, and the chemotherapy can be continued. But I will talk about this one much more soon. The second compartment in the anatomy of the eye would be uvea, which you can see in the picture. Based on the physiology of this compartment, if a damage happens to that, we can see the manifestation of the problem on variation in intraocular pressure. Specifically, we can see it as uveitis, and there are potential of vision disturbance for sure. Again, I will talk about that more, but as a very general idea, if the patient are suspected to drug-induced uveitis, we need to have an urgent referral to a specialist for some examinations. The third compartment of the anatomy of the eye will be orbit and preorbital tissues. which you can see again in the picture. The orbit itself is the cavity of the skull, which we have in the eye, and it is related to alterations of eye appearance, motility, eyelid functions, and things like that. The very important points about this compartment to mention is that orbital inflammation is an emergency. Based on the physiology of preorbital tissue, if any changes happens to that, we see that manifestation of the change by the things like abnormality of the eyelashes, scaring, the outward turning in the lower lid of the eye. And again, as a very general idea, we should mention that if something like that happens, the patient can be treated symptomatically and they can continue the treatment. In a more advanced situation, they may need to refer patient to ophthalmologist and discontinue the medication as well. And about the orbit itself, based on the physiology of that, which I mentioned sooner, if an inflammation happens, we can see the manifestation in the problems like pain in the movement of the eye, and it can be up to even potential optic neuropathy and even blindness in the patient. So, as I mentioned, if inflammation happens, it will be an emergency. We need to very immediately discontinue the drug, and very prompt evaluation by a specialist is required. The next compartment of anatomy will be retina, which you can see in the picture. Based on the physiology of the compartment, when there is a damage to that, the manifestation of the problem will be things like visual field loss, changes in the color perception, and the problems in clarity of the vision in the patient. Again, as a general idea, we can actually control the situation of retina's ocular toxicity by withholding the drug, and an urgent referral to ophthalmologist is required. And the last compartment of anatomy would be optic nerve. The approach to ocular toxicities in optic nerve will be very close and the same as retina. Based on the physiology of the compartment, if any damage happens to that, the manifestation will be the same as retina. For example, we may see that development in visual loss may happen for the patient. I can say specifically, we can see that increasing on the ocular pain happens for the patient. And again, as a general idea, if ocular toxicity in this compartment happens for the patient, we need to withhold medication and urgent referral to a specialist is required. Coming back to outline of managements, if the ocular toxicity is the root cause in the patient, and after localizing the compartment by evaluating the symptoms, the next step will be providing some general approach for managing the toxicity to each of the compartments, and also providing some managements to the common ocular toxicities and symptoms which we can see in the patient. Let's review very general approaches for each of the compartment toxicities. If you have ocular toxicity in cornea and interior segments, for the most of the cases, we can manage the situation symptomatically and continue the anti-cancer medication. If the toxicity is in uvea section and we have this suspicion that drug-induced uveitis happens, we need to have an urgent referral to ophthalmologist. The next one, if preocular tissue changes happen, we can manage the situation symptomatically and continue the medication. In very advanced cases, we need to have a referral to a specialist. For the orbits, as I mentioned before, if orbital inflammation happens, that is an emergency, so we need a prompt drug discontinuation, and evaluation by a specialist is required. And finally, in the cases of retina and optic nerve, we need to withhold, and urgent ophthalmologist referral is required. And now, after some general approaches for each of the compartment toxicity, it would be good to have a quick management to very common symptoms: dry eye, blepharitis, and conjunctivitis. For the case of dry eye, lubrication with artificial tears would help a lot. The artificial tears generally have cellulose, which maintains the viscosity in the eye. They have some spreading agents, which prevent the evaporation, and has preservative, which prevent the contamination in the eye. The patient's dry eye, if the patient's dry eye is in a very severe cases, then in some cases we can use even topical steroid for a short amount of time. For the cases of blepharitis, if our toxicity is mild, we can do daily lid scrubs with baby shampoo or warm water. And besides that, we may use antibiotic ointment for the lash line as well. Consider that in some cases, we may need to use topical antibiotic with topical steroid. And in the cases of very severe blepharitis, we may need to use systemic antibiotic instead of topical. On those cases, doxycycline would be a very good option. And finally, for conjunctivitis, consider that this can be due to infectious and also allergic etiology as well. Therefore, in getting history from the patient, it is very important to ask that if the patient has any contact with someone with infectious conjunctivitis recently, or ask about symptoms of seasonal allergy. About conjunctivitis, if it happens from the medications like doxorubicin, we should know that it will resolve quickly itself after stopping the medication or finish. Let's start with question number 1. KS is a 67 years old female who started bortezomib as a part of bortezomib, lenalidomide, dexamethasone regimen for multiple myeloma. She had developed mild swelling of the eyelids, which appear greasy, along with red eyes and crusted eyelashes. What is the best treatment option for this case? And answers: A, daily lid scrubs with baby shampoo and warm water plus antibiotic ointment in lash line. B, systemic doxycycline. C, warm daily compress. And D, gel eye lubrication with topical steroids.
A lot of A's in this room.
Okay. And as we can see, the symptoms shows that it is probably blepharitis. And in these cases, we goes with option A, which is daily lid scrubs with baby shampoo or warm water plus antibiotic ointment in lash. Coming back to the outlines, after providing management for common symptoms, our final step will be focusing on a specific management for a specific anti-cancer medications. Let's categorize anti-cancer therapy to 3 types: immunotherapy, targeted therapy, and chemotherapy. And start with immunotherapy as the first. One of the most important part of immunotherapy in oncology is checkpoint inhibitors. They're immunomodulatory antibodies which enhance body's immune response against the cancer by targeting some specific protein which regulate the immune checkpoints in our body. They have 4 types of mechanisms, which some of them are in group of CTLA inhibitors like ipilimumab. Another one is PD-1 inhibitors, which is pembrolizumab. Another one is PD-L1 inhibitors like atezolizumab. And the last group, LAG-3 inhibitors. We can see that different ocular toxicities may happen with these medications. For example, following blocking CTLA inhibitors with ipilimumab, we may see that eye inflammation, episcleritis, conjunctivitis, uveitis, and even orbital inflammation happens for the patient. We can see symptoms like photophobia, pain, dryness of the eye, and blurred vision happens with ipilimumab. Another ocular toxicities with checkpoint inhibitors, which is rare, but it is important, can be intraocular inflammation, like uveitis specific. Following the treatment of the patient with PD-1 inhibitors, like with pembrolizumab or nivolumab, uveitis may happen. So how to manage that? The very first point, which I like to repeat again, is if orbital inflammation happens, it is an emergency. And then to treat this autoimmune toxicity in the patient, the very first point is discontinuing the medication. In many cases, we need to refer the patient to a specialist. If the patient is in a lower grade toxicity, we can use topical steroid, like, for example, the drops of prednisolone. And that specifically works in improving the vision of the patient in cases like uveitis, iritis, episcleritis. And other than topical steroids, in 3 situations, we may go with systemic steroids. 1, in the patients who are in advanced grade. 2, in the patients who are in refractory toxicity. And 3, in the patients who has another concurrent autoimmune toxicity inside the body. I also like to mention specifically about the case of ipilimumab, that if these immune-mediated ocular toxicity happen in the patient who has ipilimumab, and it is in grade 2 to 4, and we cannot improve it to grade 1 in 2 weeks, with topical or oral therapy, we need to discontinue medication permanently. Let's start question number 2. TD is a 62 years old female who began a regimen of ipilimumab and nivolumab as a second-line therapy for renal cell carcinoma. 2 weeks after starting the therapy, she developed grade 2 uveitis. What would be the best treatment for her toxicity? A, no treatment is required. B, ophthalmic prednisolone 1%. C, oral prednisolone 10 milligram daily. And D, IV methylprednisolone 1.6 milligram per kilogram per day.
Hearing bees in this room.
As we can see, the patient is in a dual therapy of checkpoint inhibitors, uveitis, which is an autoimmune toxicity here, can happen with both of the medications, which one of them is CTLA-4 inhibitor and another one is PD-1 inhibitor. After discontinuing the medication, because uveitis is not grade 3, it is not refractory, and there is no concurrent autoimmune toxicity with the patient, we can go with topical steroids. So as you mentioned, option B is the correct one, ophthalmic prednisolone 1%. Coming back to the 3 categories, after talking about immunotherapy, let's focus on targeted therapy, which is a very long section here. And I want to talk about 9 different groups of the medications today. The very first group of the targeted therapy would be EGFR inhibitors. EGFR itself are receptors of epidermal growth factors in the cell. So by inhibiting those receptors with these medications, we can prevent the cell growth. In this class, we have monoclonal antibodies like panitumumab, and also we have small molecules like erlotinib. It is common in this class that the compartment of cornea and interior segments developed toxicity. For example, we can see that corneal erosion or, for example, eyelash trichomegaly happens with cetuximab. Or, for example, with panitumumab, we can see conjunctivitis. We can see with erlotinib that in some patients, corneal thinning or eyelid changes happens. As I mentioned sooner, if toxicity happened with this compartment, we can continue the medication after, of course, evaluating the risk and benefit and symptomatically manage patients. I like to mention that with this class of medications, we may have a poor healing of outer epithelial layer of cornea. So on those patients, dry eye can happen. Besides dry eye, we may have epithelial defects and also erosions. Finally, patient may have symptoms like blurred eye, and we can see that in the patient. If that situation happens with this class, artificial tears, bandage to contact lenses, and patching would be a very good option for those patients. Just consider that those epithelial defects are reversible. So after stopping the medication, they will be in a normal situation in patient. Amivantamab, which is a monoclonal antibody of this group, specifically can develop keratitis in this compartment of the eye. Based on the medication's package insert, we see that if ocular toxicity happens, we need a prompt specialist referral. And also, I like to mention that the package insert of this medication provides guideline on how to do dose modification based on the symptoms severity if it happens on the patient. Another compartment and toxicity which can be developed with this class is interior uveitis, which happens with erlotinib. It is rare, but again, it is very important. We need to discontinue medication in that cases. And if we are in the recurrent situation after rechallenging the medication and we do not have any alternation, we need to really evaluate risk and benefit for the patient if we want to continue. So it will be a very complicated situation. If those type of uveitis happens, we can consider topical steroid for the patients. Another compartment which may develop toxicity with this class is orbits and preorbital tissue. If that happens, we need to discontinue medication. I like to mention about this class that they affect the regulation of hair circles as well. So we may see that, for example, alopecia, changes in hair color, the growth rate, the texture of the color happens. And besides all of them, pterygomegaly. Besides changes in the hair, we may see that changes in the preocular skin actually may happen. So we may see, for example, edema, erythema, and blepharitis with this group. The side effects which we can see in this situation is generally mild, and it is reversible after discontinuing the medication.
I do have a question about if there is benefit for referral for trimming the eyelashes to avoid abrasion in those situations where the patient has trichomegaly.
So what's the question?
Is there benefit for referral for trimming the eyelashes to avoid abrasion?
I think so. Yes, for sure.
Yeah, absolutely. Thank you.
The next group of targeted therapies is HER2 inhibitors. And with blocking those HER2s, we can block the cell cycle progression. Agents like trastuzumab is in this class, which can be related to making many toxicities. First compartment, which can be affected, is cornea and interior segments. Symptoms which are related in this situation can be mild. You can see dry eye and associated tearing with that. Blurred vision may happen in some patients. And if that happens, like other cornea situations, we can continue the medication and manage symptoms have a common management of the symptoms. Another compartment which can be affected is retina. It is rare, but if that happened with trastuzumab, we may see that macular edema, macular ischemia, and even retinal detachment may happen for the patient as well. These situations can be serious, and maybe vision loss can happen for the patient. So if we see that retina is getting affected, we need to discontinue the medication, and referral to a specialist needs to be done. BRAF inhibitors is the next class. They inhibit the uncontrolled tumor cell division, and agents like encorafenib are in this class. Cornea and interior segments may develop a mild type of dry eyes and conjunctivitis, which can be managed in common symptom managements, and in most of the cases, we can continue medication. Uveitis is very important ocular toxicity with this class, which may happen even up to 7% of the patients. It can be very mild, but it can be even very serious in some patients, and we may see even retinal detachment by that. Due to that important uveitis, we need to assess the visual symptoms of the patient in each visit. If the case of that uveitis is mild, we can continue the medication. And it is very important to know that in majority of cases, we can manage the patient successfully with a steroid. But if the patient actually let us know that there is a clinical symptoms is happening, we need to evaluate patient promptly. So we cannot wait for the next visits. And in many cases, we need to actually evaluate it, and we need to refer it to ophthalmologist as well. If we see that there is no improvement is happening, or the case is severe, like panuveitis, we need to discontinue the medication for sure. In the package insert of encorafenib, we can see that there are specific approaches for uveitis. If that toxicity happens in the patient, we need to have evaluation by a specialist for any new or worsening disturbance of the eye in irregular intervals. If the uveitis of grade 1 or 2 happens and it is not responding to our therapy, we need to withhold the medication. Also, if grade 3 uveitis happens, we need to withhold medication in any cases. And if you're doing those withholding, it should be up to 6 weeks. If the symptoms are improving, then we can resume the medication. We can have the same or reduced doses. But if the patient is not improving, then we need to discontinue encorafenib permanently. One specific ocular toxicity, which we can see with vemurafenib, and in some cases it is reported with dabrafenib as well, is squamoproliferative lesions, which on those cases we may see that a squamous cell carcinoma is developed in the patient. If that lesions are developed in the patient, we normally see it in the first 3 months of starting the therapy. And it can happen in sun-protected sites of the eye as well. If that happens, we can continue the medication without those adjustments. However, the specialist needs to do biopsy, excising the lesion, reconstructing the defects, and also preventing the eyelid from closure to protect the whole eye as well. Next class is MEK inhibitors. They affect the cell proliferation and induce apoptosis in the tumor cells. Termetinib is one of the medications in this case. And this class has a very important ocular toxicities in retina compartment. The very first one, which we see with cobimetinib and termetinib, is RVO, the retinal vein occlusion. It is uncommon and it may happen in 0.2% of the patient, but it is very severe. If that one developed in the patient, we definitely need to have a specialist referral. In some cases, for managing it and for optimizing the vision in the right setting, we may even need to use intraocular VEGF inhibitor for the patient. Other retinopathies also can be developed with this class in the patient. The incidence is very high. It can be even up to 57%. Because it is different types of retinopathy which can happen, we may see a very wide range of symptoms and retinopathies. And it can be even very severe, up to retinal detachments in the medication as well. Consider that other situations like macular edema, visual disturbance, all of them can happen in the patient in those situations. I also like to mention that if we see this ocular toxicity in those patients, we normally see it in the first week of the first dose. So consider that. We can see in the package insert of termetinib that there are some recommendations for ophthalmologist examination in a regular intervals through the therapy in any new or worsening visual disturbance. If we have a documented retinal detachment, we need to withhold the medication. And if we want to restart the medication, it needs to be reduced dose if we have a documented resolution of the situation in 3 weeks. If we have no improvement through that 3 weeks, if we have a recurrence retinopathy, or if we have any case of RVO, we need to discontinue this medication permanently. In the package insert of cobimetinib, it is kind of very close and same as termetinib. There's a recommendation for ophthalmologist examination in irregular intervals. In a case of serous retinopathy, we need to interrupt the therapy until we have some improvement, and we can restart the medication if we improve it in 4 weeks here. if you want to restart the medication, it should be in reduced dose. In any case of recurrence or in any case of RVO, we need to discontinue medication permanently. The next class is FGFR inhibitors, which they actually prevent the tumor cell activity. Considering that FGFR and MEK pathways in the cell, they have overlap with each other, inhibiting one of those pathways make a similar toxicities with the other one as well. So considering that those retinopathies, the retinopathies which happens with this class is kind of the same as MEK inhibitor associated retinopathy. I'd like to mention that with this class, we may see lots of dry eyes and also eyelash pterygomegaly as well. In the package insert of erlotinib, there's a recommendation for using ocular demulcent because of that dry eye as a prophylaxis for all of the patients. And a specialist examination needs to be done monthly in the first 4 months. And after that 4 months, we can do the examination every 3 months. And if any new or, of course, visual problem is happening, we need to do that checks of examination again as well. In the case of serous retinal toxicity, we need to withhold the medication. And on those situations, the specialist evaluation needs to actually be done in 2 weeks for sure, for making decision if you want to restart or medication and in what dose. Consider that this package insert has some guidelines for dose modification for the drug as well. In the package insert of pemigatinib, we can see that there is a recommendations for a specialist evaluation prior to the therapy and every 2 months in the first 6 months. After that 6 months, we can see the examination. We can do the examination in every 3 months, and whenever there is a new problem. And this package insert also provides dose modification guideline as well. The package insert of infigratinib, we can see it is similar to pemigatinib. There are some very small differences in the interval of the checks, which you can see in the slide. And about the package insert of ponatinib, we can see that there's a recommendation for ophthalmologist examination prior to the therapy, and here they mention periodic. ALK inhibitors is the next group, which they inhibit the abnormal growth of the tumor cells, and medications like ceritinib are in this group. We can see that the visual disturbance, like for example, trailing of the light, flashes, or brief image persistence is very common with the medications like crizitinib. It can happen even up to 65% of the patients. The onset is typically on the first week of starting crizitinib. This type of visual disturbance can happen with all of the medications in this group, but the incidence is much more lower. It is less than 15%. Considering that these situations and symptoms getting better daily, and they last up like 1 minute when they happen, they have a very little or no impact to the daily activity of the patients. Therefore, we do not need to stop the medication, and we can just manage the patient in a symptomatic situation. In the package insert of crizitinib, we can see that in the case of very severe visual loss, we need to make a decision for the patients individually if we want to resume the therapy between the benefits and the risks, which can be really a vision loss for the patient. In the package insert of brigatinib, we can see that if the patient is in grade 2 or grade 3 of vision loss, we need to hold the medication until we have grade 1. And considering grade 1 is a symptomatic situation. And if we want to restart the medication, we need to do it with reduced dose. Also, in the case of grade 4 of vision loss, which is generally kind of a blindness, we need to permanently discontinue medication. The next class is SERPs. They're receptor modulators, and they can act as agonists or antagonists of estrogen receptors based in which tissue they are working on, like tamoxifen. Corneal deposit happens in this class, and the incidence is less than 1%. Another thing which can happen with this class is cataract. That actually can happen in less than 5% incidence. In both of these situations, we can continue the medication. In more severe situations, there are some approaches which you can see in this slide. Like I mentioned about corneal, generally cases, we need to have referral to ophthalmologists. And the reason of that is that corneal deposit may develop a macular edema on the patients. And in some of the cases, that can be followed by even vision loss. In many cases, that can be resolved after discontinuing the medication. However, in some cases, we may see that pigmentary changes and retinal deposit persist in the patient. Therefore, it would be good to be under control through the therapy and having a good follow-up through the time. And now, let's talk a bit about tyrosine kinase inhibitors that was not in the previous group and I haven't mentioned until now, but they're very important medications in oncology. Imatinib is one of them. We can see that's periorbital edema with a mild to moderate situation can happen with imatinib. The incidence is high. And also in these situations, we can continue the medication, but we can manage it with topical steroid and diuretics. Another toxicity which happens is epiphora. We can manage that with we need to discontinue the medication on that situation. And also another thing which happens with imatinib is a benign form of spontaneous subconjunctival hemorrhage, which on that hemorrhage, there's an absence of systemic bleeding and also bone marrow suppression is absent as well. The picture of the eye on that situation is displeasing. However, there is no requirement for stopping and discontinuing the medication. I like to mention also that with imatinib, in some rare cases, optic neuritis may happen, which that can be developed to vision loss in the patients. On that situation, we need to definitely discontinue the medication. Another medication is vondatinib. That can be associated with corneal deposit. Just please consider that that can happen in a rare incidence, and we can manage by steps, as you can see in the slide. Sorafenib can be associated with squamoproliferative lesions, and that can affect the eyelid of the patients. The treatment of that toxicity is the same as the situation when the lesion happens without any sorafenib. And the next medication is ibrutinib, which it is in the group of Bruton tyrosine kinase inhibitors. That medication has several ophthalmic side effects, like, for example, blurred vision, dry eye, increasing lacrimation, uveitis. And if uveitis happens, we need to have a referral to a specialist. And the last group of targeted therapies, antibody drug conjugates. These are combination of monoclonal antibody in one side, which helps the medication to target tumor, the antigen in the tumor, and the other side, we have the drug, which can lead to tumor, which can finally lead tumor cells to have apoptosis. I want to mention 4 medications here in this class. Belantamab mafodotin is one of them, which that is approved before, but then later voluntarily they peeled off it from the market because the treatment's inefficacy. I just like to mention that it has multiple common ocular toxicities when it was in the market. Enfortumab vedotin is the next one. We can see dry eye, blurred vision, and increasing lacrimation with this medication. Based on the package insert of the medication, we need to have a prophylaxis with artificial tear for the patients for that dry eye, and ophthalmologic evaluation needs to happen for ocular symptoms if they are not resolving. And if we want to have a symptomatic ocular covering and management, we can use ophthalmic topical steroids and, of course, drug interruption and drug dose reduction as well. About tisotumab vedotin, we can see that conjunctival, corneal, preorbital problems may happen for the patient. We may see dry eye and increasing lacrimation on the patient. On the package insert of this medication, ophthalmic examination by the specialist also mentioned. There's some specific examination which is required. And prior to starting the therapy, we need to do those examinations, and also prior to each dose. All of the patient needs to receive topical steroid and vasoconstrictor eye drop as well, prior to each dose. Through the drug infusion, patient can have eye cooling pad as well. And also the patient needs to have eye lubrication during the therapy and also 30 days after discontinuing the medication as well. And generally, we should avoid the patient from wearing the contact lens as well. This package insert provides the guidelines for dose modification based on the severity of the toxicity for the patient. The last one, mirvetuximab soravtansine, and that can have a severe ocular toxicity in the box warning of the patient, vision impairment, keratopathy, dry eye, and some others can be seen with the patients. The very important thing is median time for starting that ocular toxicity is 1.2 months in the patient. Per package insert of this medication, it is required to do the tests prior to starting of the therapy and prior to each dose in the first 8 cycles of the medication.
Every other dose.
Every other dose, I'm sorry. There is a need for perimedication to be used with ophthalmic steroid. And also we need to use artificial tears as lubrication. For this one as well, we need to mention to avoid contact lenses. And based on the severity of ocular toxicity, we may need to withhold or reduce the dose or discontinue medication. After a very long round about the targeted therapy, I will come back to the 3 categories of the anti-cancer medication. And now let's have a fast review for conventional chemotherapies. First of all, taxanes. In the first step, docetaxel may actually make epiphora with excess tearing. And also in that situation, we need to refer patients to lacrimal specialists. Paclitaxel is another one. We know that it may have actually visual changes, and we may see that through the infusion for the patient, and it can be reversible after the end. 5-FU is another medication. Ocular toxicities is lots in this medication, which you can see in the picture. Busulfan may make cataract, specifically 13% with the population of pediatrics. Carmosin can have a severe cases of optic disc edema or many different retinopathies, which discontinuation is required with this situation. And with cytarabine, it can be associated with corneal deposit, which is dose dependent. And it has a very high incidence when our dose is 3 or more than 3 grams per meter square. And on those situations, patient may have symptoms like conjunctival, injection, photophobia, foreign body sensation, and some mild to moderate vision loss. And for actually, it is reversible after stopping the medication. And prophylactic prednisolone eye drop can help the patient for symptomatic management. Anthracyclines, doxorubicin can make conjunctivitis. Platinum class can make some rare, actually, ischemic retinopathy. On that situation, discontinuation and referral is required. And vincristine can actually, it is uncommon, but it can actually make some nerve damage and optic neuropathy as well. And let's start our last question. JF is a 55-year-old female who has been diagnosed with Burkitt type lymphoma and will start a hyper-CVAD regimen, which chemotherapy medication in her regimen requires consideration of glucocorticoid ophthalmic drop for the prophylaxis of corneal deposit. A, cyclophosphamide, B, vincristine, C, cytarabine, D, doxorubicin. Yes, great. So as we mentioned in the last slide, cytarabine can make ocular toxicities of corneal deposit, specifically when it is 3 grams, more than 3 grams per meter square. We can use that drop every 12 hours for 3 days for sure. And you can see this is the references of the package inserts we use. And at the end, I'd like to appreciate Dr. Olivia Fahey for my supervising in making this presentation. And at the end, this is the instruction for having credits, and you can take a picture from that. Thank you so much.
Thanks again, everyone, for joining us today. Once again, if you're in a shared location, please drop the name of everyone who was signed in with you into the chat for attendance purposes. And if people want to stay, we can answer questions for a few minutes.
Fine. You can thank you in the chat as well.